Good afternoon, everyone, and thank you for joining us for the webinar today, Responding to People in Crisis, Part 1, Identifying Familiar Faces. We'll get started in a few minutes to allow for some additional sign-ins past the hour.
Good afternoon, everyone, and thank you for joining us for the webinar today. Today's webinar is Responding to People in Crisis, Part 1, Identifying Familiar Faces. My name is Mark Stovall, and I'm a Senior Policy Analyst here at the Council of State Governments Justice Center, and I'll be moderating today's webinar. And as the title of today's webinar suggests, this is Part 1 of a three-part series of webinars that we're doing this year. And we're excited to have representatives from 3 different counties joining us for the webinar today. And these counties are both Stepping Up Innovator Counties and MacArthur Foundation Safety and Justice Challenge Counties. And we'll talk a little bit more about what that means in a minute. But before I move on, I want to mention a few housekeeping items. So during the webinar today, you can ask a question by typing it into the Q&A panel on the bottom right-hand portion of your screen. And we'll respond to the technical questions as we go, and then keep a running list of the content-related questions and hold them until the Q&A section at the end of the webinar. And we're also recording this webinar, and a recording along with the slide deck should be available on the Justice Center's website by the end of next week. So to give you an overview of the webinar today, we'll start with some introductions, and then I'll turn things over to my colleague, Risa Hannenberg, who will talk a little bit about Stepping Up and the MacArthur Safety and Justice Challenge. And then we'll take a bit of time to hear from our county representatives to discuss their Familiar Faces projects and their crisis systems of care. And then at the end of the webinar, we'll do a Q&A, and we'll hear from the panelists to answer the questions that come in from the audience. And then we're excited to hold a follow-up office hours event after this webinar to continue the discussion on the webinar next month, or the discussion from today's webinar to continue the discussion next month. So let me turn to a few introductions. We have my colleague, Risa Hannenberg, who's Deputy Division Director in the Behavioral Health Division at the CSG Justice Center. We have Nicholas Hageney, Court Policy Analyst of the Superior Court of Fulton County in Georgia. And we also have Kristen Schillig, Court Support Manager, also from the Superior Court of Fulton County. Myself, Mark Stovall, Senior Policy Analyst at the CSG Justice Center. Andy Utes, Program Planner from Polk County Health Services in Iowa. And Charlie Verploeg, Assistant Director of Bernalillo County Department of Behavioral Health Services in New Mexico. And now I'll turn things over to my colleague, Risa Hannenberg, who will talk a little bit about the Stepping Up Initiative and the MacArthur Foundation Safety and Justice Challenge.
Thanks, Mark. Next slide. So first of all, I too just want to join in with Mark and welcoming all of you today. This is a project that we've been working jointly with these three sites, basically just trying to leverage all the great work that they're doing, both through as being a Stepping Up Innovator site and then their work with the MacArthur Safety and Justice Challenge. Just a little bit about the Council of State Governments Justice Center for those of you who are maybe new to turning into these webinars. But the Justice Center is a non-for-profit agency that we push work in the criminal justice arena, and particularly in the division that Mark and I work in. The behavior health is really concentrating on that intersection of behavior health and criminal justice. And you will be able to find all kinds of resources if you go to the website for both the Justice Center and Stepping Up. Next slide. And there we go. So and then just a little bit more, if you will, about the Stepping Up initiative. This is a project that I have been working on now. We actually are honestly on our 6th-year anniversary, I think tomorrow, for Stepping Up and the launch. And it is an initiative that we work closely with NACO, the National Association of Counties, and the American Psychiatric Association. And it is a national initiative to reduce the number of people with mental illnesses and co-occurring substance use disorders in jails across the country. Next slide. I think we went a couple too many. We need to go back one more. Sorry. Okay, next slide. And I did that slide. There we go. So, okay, thank you. I'm sorry for that. So just to, again, reiterate a little bit about what Mark introduced in that opening, but this will be a 3-part webinar series featuring these 3 Stepping Up and SJC sites. And today is obviously part 1, and then we have also scheduled for part 2 and part 3. And we will be focusing on the population of, we're calling them familiar faces. You may refer to them as high utilizers, but those individuals that are coming through and touching not only the justice system through jails, but also we see are frequenting services through local emergency rooms, homeless shelters, emergency services, you know, just touching all kinds of resources in the community. And when you're able to identify these individuals, how you can focus your efforts there, and with the goals of obviously keeping them from being reentering into the justice system, but also stabilizing them and working with them as they remain in communities. So we really wanted to, you know, if you will, focus in on all of the efforts that are being done across the country right now in addressing crisis and crisis response, and then realizing that is this population of the familiar faces that are many times cycling in and out of crisis on a rather cyclic basis. So that's primarily the population that these 3 webinar series will be addressing. And then in addition to the 3 webinars, we're offering what we're calling office hours, and that will just be a time that will be offered for anybody who's interested to call in and just be able to pose questions and be more involved in somewhat of an informal conversation with the 3 sites and with Mark and myself, just talking about this population, talking about challenges you're facing, and also learning from everybody involved as far as what's working. Next slide. So I also wanted to, as I was saying, I feel like across the country there's so much focus right now on crisis and crisis response. And so I just wanted to announce, it's actually approaching next week on May 20th, but there will be an opportunity to learn about the launching of what we're calling Taking the Call. It is going to be just an introduction to an upcoming convening that will be held in October, sponsored by the Department of Justice, Bureau of Justice Assistance, along with the folks here at the Justice Center, and then many other key partners from across the country, to spend some time, first of all, learning about what this convening is going to involve. As I said, it's going to be October 20th and 21st, and then also learning and gleaning from those who are willing to share with us the challenges and the barriers and so forth that everyone is addressing right now across the country. So I hope you can mark your calendar for this Taking the Call event next week on May 20th. And I think then we're going to do a poll. There we go. So if everybody wants to participate, we have a polling question for you right now. It says, does your county have a familiar faces or frequent utilizer project to identify and serve people who have repeated contact with criminal justice, behavioral health, and social service systems? So your options: yes, we're implementing it; yes, still planning; or no. And we'll just give you a couple minutes to mark your response. I'll let you know when that polling is going to close. Okay, I can see now that the responses have popped up for us. So I know you can see this, but just so you can see from the results today, it looks like we are a little bit split, if you will, between those who are in the process of implementing and those who are in the process of planning, and then the no answer. So that is a response from, 74 out of 173 of you today. So we want to thank you for participating. And looks like we kind of almost have a three-way split here on this. So we'll all be learning, I think, together today. So thank you. And I will be turning it back to Mark. Actually, I think I'm turning it to Charlie.
Hi, everyone. Thanks for joining today. I'm really glad for the opportunity to get to speak with you a little bit. My name is Charlie Verplew. I'm the Assistant Director for the Department of Behavioral Health Services here in Bernalillo County in Albuquerque, New Mexico. I am a sociologist by training, a background in quantitative research methodology, research evaluation, social psychology. But today I'm here to talk to you a little bit about how we identify frequent utilizers here in Bernalillo County and what we've done to go through the process of identifying them and then building out a system of care to connect them to. We've been working for many years here in Bernalillo County to address and mitigate the gaps in the behavioral health continuum. And a really important part of this process of addressing and mitigating those gaps is determining who's engaging with behavioral health systems, criminal justice systems, service systems at really high rates, and being able to engage that population into services. Therefore, the ability to identify who those individuals are, create a system of care for those individuals to support them, and also having a way to connect them to longer term supports is really, really important for having an overall continuum of care for behavioral health. So today I'm going to talk to you a little bit about the development of our high utilizer list here in Bernalillo County, the crisis continuum of care in Bernalillo County that we've made efforts to build out, how we connect individuals that are high utilizers to that crisis continuum, and then a little bit about some ongoing challenges that we continue to face. Next slide, please. So how do we identify high utilizers here in Bernalillo County? Well, our frequent utilizer tool was created to identify frequent clients of Bernalillo County services. So the tool was first introduced in April 2019. It consistently identifies about 230 to 250 individuals each month. Those individuals have 2 bookings in our local jail called the Metropolitan Detention Center. And they've used either our public inebriate intervention program, which is a sobering service, or one of our care campus programs like our detox program. I wanted to walk you through a little bit of the process of the development of that list, because I think as you're working through your own list, it's interesting and exciting to learn how other people do this. So we start with a base of 18 months of booking data out of our Metropolitan Detention Center. Then we match that data with 3 months of data from our care campus, so that sobering unit that I talked about or that detox program. And then that list is weighted by how many emergency room visits those clients had. We maintain 2 lists, so we have an active list and we have a watch list. Those who match are compared with previous lists, and they yield anywhere from 30 to 40 new additions to that active list each time we go through and update the list itself. Clients currently on the active list who have not had a booking or a visit to the care campus for 3 months or so are dropped off to that watch list. And then clients stay on the watch list until they have had no bookings or no visits to the care campus for over a year. Then they get dropped off that watch list completely. Clients who are on the watch list and have had a care campus visit or a new booking into the jail, then they get upgraded back to that active list. So that's basically how that process works. Next slide, please. I wanted to talk to you briefly about what do we do with that active list. So the clients that are flagged on that active list are sent into our Department of Behavioral Health database. And then if someone comes into that public inebriate intervention program or they come into that detox program, they're flagged as a frequent utilizer, and then we connect them directly with intensive case management upon entry. So that's really an important process to be able to say, oh, you're a frequent utilizer, you're going to need new case management services along with the services that you've come to attend here on the campus. We also provide that active list to our resource reentry center that I'll tell you a little bit about here in a minute, but that's our integration system from the jail back into community. And we identify people on that utilization list, we send it to the RRC, and then when individuals are being contacted in the jail for case management services, they're identified as high utilizers. And then also once they come out of jail, they're releasing through that resource reentry center, they're also flagged again at that moment saying, hey, we see that you're engaging in services a lot. What else do you need? And identifying them an intensive case manager and providing extra services to those individuals in order to sort of impact that recidivism rate that we're seeing for those particular clients. A little bit about future plans for this list. So we are working on sharing that list through what we're calling a secure portal. So it's in development. It's a partnership with our city agencies, other community partners, legal partners, in order to identify who's a frequent utilizer and then also provide wraparound services for those clients. Next slide, please. I wanted to tell you a little bit about the next steps that we see for this utilizer list. So what we know is that we need to do a better job at identifying who's a high utilizer here in Bernalillo County. And as a whole, we want to make sure that we're working to reduce the use of high acuity services like the jail or the emergency room, and instead connecting those frequent utilizers to appropriate services. In order to do that, we really need to have be able to share that list, identify who's on that list, and then be able to move forward with that process of case coordination. We decided that the best place to have this conversation was in our high frequency utilizer work group. It's a bit of a mouthful. That work group comes out of our Criminal Justice Coordinating Council here in Bernalillo County. And so it's a subgroup of that CJC Coordinating Council. That CJC work group is really designed to create a strategic plan for public safety and work on the Stepping Up initiative. So goals like reducing the number of people with behavioral health needs in the jail, reducing the length of stay for those individuals in the jail, and then increasing connections to resources once they leave the jail. So those are those high-level goals that that committee is working on. In initial meetings for that work group, they did a couple of things. So they decided that they really needed to establish the definition of a high utilizer. So they started with our definition that I described earlier. They definitely want to include ER and ED visits, number of bookings a year into the MDC Metropolitan Detention Center. And then there might be other indicators that other providers find really important. So they're in conversation about what those indicators are to expand that list. Then they wanted to highlight the need to share that information across groups in our community. So it's great to have the list, but then you need the opportunity to be able to share that list across providers. And then to address the social and the legal barriers related to the sharing of that information. The group recognized the importance of including a lot of individuals in that conversation. So I wanted to mention a few here. So legal representatives, members of the criminal justice system, including judges, behavioral health and jail representatives, local homeless and outreach community providers, law enforcement, etc. So that group started with about 6 individuals and it's grown to 38 members. So it's gotten quite large, but that's because of the importance of this matter for our community. Next slide, please. I want to tell you about 2 things that this group is working on that I think is really important and potentially helpful to you guys, or maybe you guys are working on something similar in your jurisdictions. So those 2 things are data and information sharing MOU and the development of a universal ROI. So the universal ROI consists of multiple agencies on one document that allows a client to sign to give permission to multiple agencies to speak to each other for the purposes of case coordination. It's really important. The MOU allows members to come into conversation with each other, view that high frequency utilizer list into one location, and then be able to see clients that have signed that particular universal ROI so that they can engage with each other and say, hey, my client is also being seen by you. Can we talk with each other about some process for case coordination in order to mitigate some of the duplication that might be occurring in terms of service provision? Both the MOU and the ROI reduce that duplication of efforts. And also, I think at some point, our hope is that it's going to allow law enforcement another outcome option so they can engage clients with providers and community rather than taking them directly to jail or ER as like the only option for them to potentially provide engagement outside of where that individual is located in the community. So those are 2 things that we think that this process will do. One thing that I'll mention here is that that high frequency utilizer group has had to engage with another subgroup of the CJCC. They're called the data integration group. And the process for that is to be able to fund and build a data integration database, basically, that allows us to house the high frequency utilizer list and also store those universal ROIs. The application is currently being built out by our New Mexico Tech, and it gives permission settings according to that universal ROI. The high frequency utilizer list will also include the name of the primary agency assigned to the client, so services can be diverted back to the provider versus the jail or ER. So we're really excited about the process. We're in the midst of developing it. So excited to talk to you guys about any questions or ideas that you might have related to what you're doing in your own communities. Next slide, please. I wanted to mention here, and so many things I want to talk to you guys about today, but one of the things I wanted to talk to you about is that the crisis continuum of care, right? That there's more services than just developing out a list. Then we need to be able to identify what services the people on that list need to go to and how to get them there. So what we found is that people enter into crisis in multiple locations in the system, and that we have other services in our crisis continuum that address both the before and the after in terms of that crisis response. So I'm going to talk about just a few of these at a really high level today. I want to talk about our Resource Reentry Center briefly, our law enforcement assisted diversion program, our mobile crisis teams, our community engagement teams, and our CTC, or what we refer to as our crisis stabilization unit. It's important to note here that when we're talking about crisis services, that we don't just talk about developing a list, and we don't just talk about who we call to respond to a crisis, but we also talk about so who to call, who to respond and where to go is this framework that this group has been talking through as a way to think about what we need to develop out a crisis continuum of care. On this call, I'm mostly going to talk about who to call, but there's a lot of information to share or I'm going to talk about who to respond, but there's a lot of information to talk about who to call and where to go. Those pieces are also really important. In terms of who to call, in most cases, we're using our 911 dispatch system. We also have a New Mexico crisis and access line that's a little bit for lower acuity calls. There's some communication between dispatch and that crisis line. And then we're also developing out a 988 system here in New Mexico, as many of you are as well, I assume. So we're really excited about that process and trying to develop systems for people to engage into behavioral health services without necessarily always going through that 911 system. In terms of where to go, there's a variety of programs that we do in terms of prevention, housing, community supports buckets that encompass a lot of different types of services. I'm not going to go into all of them today, but I wanted to mention them briefly. So for example, a single site is a space that we've developed here that's really important. So that's a space where there's a bunch of apartments in one location with services on site. That's been really important for some of these really higher acuity clients that can't be housed in a scattered site apartment with connected to case management services. They need those services on site. So that's a place to go that we're developing out. Scattered site, like I mentioned, so that's apartments connected to case management services, some youth transitional living services or services for kids and being able to connect them to housing, drop-in centers, living room models. The list can go on in terms of the where to go type of resources that you need to build out this crisis continuum. I'll mention here that our department also oversees a campus that in and of itself is a bit of a continuum of care for crisis. So by December, we're going to have an outpatient clinic, a living room model, a training center, an observation and assessment unit, a detox unit, a crisis unit, and a transitional living program. So those are a lot of services, but we found that that's really important to be encompassed in one space. So it's kind of that one-stop shop where someone can come in, where they're at, engage in services, and go all the way through their journey in one location, and then be connected and reintegrated back into community once they've engaged with those services. Next slide, please. So now I'm going to kind of give you a real high level. You guys can get these slides at the end, so I won't go through all the details, but I wanted to mention our Resource Reentry Center. This is really that one stop for individuals that are releasing out of the jail, making sure that they connect to services as they're reintegrating in community. We engage them in the jail, and then once they release, they go through the center, again, try to engage them, and then offer them opportunity to engage longer term services after that. Next slide, please. We have a LEAD program, so that's a law enforcement assisted diversion program. Basically what it does is offers discretionary authority to officers who suspect someone of committing a nonviolent crime, or they have committed a low-level nonviolent crime, and giving them the opportunity to connect them to services if they think that that criminal involvement is related to a behavioral health need. So you have a client, you're working with them as a law enforcement officer, you think they have a behavioral health need, they're engaging in maybe some shoplifting to be able to support their drug habit, and you're saying, hey, I'd like to connect you to services rather than take you to jail. Are you open to that? And then there's an opportunity to connect them right there in real time to a case manager, and then connect them to future supports after that. Next slide, please. We have some mobile crisis teams that are really cool. So these are individuals that are experiencing a nonviolent behavioral health crisis that necessitated a 911 response. We have 6 teams, 4 APD, that's our Albuquerque Police Department, and 2 Bernalillo County Sheriff's Office teams. And they consist of a crisis intervention unit deputy that's paired with a master's level behavioral health clinician. They respond to those behavioral health calls that come through that 911 system. Next slide, please. We also have a fire team that I'm really excited to talk to you guys about. This is a paramedic and a master's level behavioral health clinician that respond to calls that come through the 911 system, just slightly lower acuity than what you might see for those traditional mobile crisis teams. Next slide. This next service is the one that I'm so excited about. We just launched it. It's our community engagement teams. These are peers with some clinical supervision that go out to community, engage with individuals pre and post crisis. So we sort of see it as the mobile crisis team, the fire mobile crisis team, and then the community engagement team just below that. And those community engagement teams are peers that engage with individuals in their space, in their community, to be able to connect them and do some case coordination and case management. They have their own line. So again, when we're thinking about who to call, the community engagement teams gives that opportunity for community to call for an alternative response of sorts that doesn't go through that 911 system, that's peer focused. So really excited to be launching those teams. And then our next slide, please. Our final service that I'll mention is a crisis stabilization unit. So this you might have heard of as a crisis triage center. That's what many people call them. According to the IMD national regulation, they can only have 16 beds, and that's really in order to avoid that large institutional space, keeping it small, providing services to individuals. It's about 14-day length of stay, and it's a respite. So it's a residential respite step-down unit for individuals who don't meet that criteria for inpatient stay, but they need a space to stay, de-escalate as they start to reintegrate back into community. We have this one on the campus. I'm actually in the crisis stabilization unit as we speak, and we're also developing one out at the hospital here in Bernalillo County. That's really great, but that's not enough. If you only have 2 units providing that respite care, you really need more than that, because there's such a small bed ratio. There's more clients that are in need of that type of service than we can provide here on the unit. Next slide. The last thing that I want to talk to you about is just some problems and challenges. So one of the things we talked about on this panel as we were preparing to present to you guys is this idea that sometimes we present our services and we present our communities and what we're doing, and it all sounds really bright and shiny. And we don't talk about some of the challenges and the difficulties that we might be facing. And that's what really brings us together as entities, as jurisdictions, as other counties, right? To say, these are the things that we are challenged by. These are the things that we want to work on, right? So I'm going to talk to you about a few of those things right now. The first thing I want to mention is about timely access to services. So a lot of times we have a challenge in terms of having the right intervention at the right moment for individuals. So these systems often rely on law enforcement, criminal justice systems, hospital emergency systems, and those systems are really inundated with clients. They have a lot of individuals that they need to serve and are not always able to provide that really timely, quick response to individuals. And what we need to do is build out more services that can engage individuals before they meet that crisis level, like the community engagement teams that I mentioned, so that we can decrease that caseload that those high acuity, high cost services are receiving, and be able to have just the most acute clients be diverted to those types of services. The next thing I wanted to mention is funding. That's always a challenge everywhere. There's not enough resources to meet individuals where they're at. So for example, we don't have enough funding to build out every resource and service needed to interrupt that use of that high acuity service and provide the most appropriate intervention. The where to go is often the most limited from what I can tell. So really long wait lists for housing as an example, not having enough housing funding, housing vouchers, things like that in order to provide that support. So that support is fairly limited in terms of housing. We're seeing an exceedingly increasing demand related to the public health emergency as it relates to housing. And I would say that what this has challenged us to do in our jurisdiction is seek out a diversity of funding sources. So state funding, legislative funding, federal funding, grant funding, Medicaid funding, right? Like being able to leverage all these different sources of funding outside of what we receive from our gross receipts tax that I've used to build out many of the services that I talked to you about today. So it's great to have a gross receipts tax as we do. That's how we funded many of the services that I talked about, but we also need to think about other spaces where we can bring in more funding to be able to support things like housing. Sharing data across system is super difficult. As many of you guys may know, we have this MOU and that's one strategy, but it doesn't solve all the problems. And really what I would suggest is it relates back to the item before related to funding. We need a large data integration system. The one we're building out is about $70,000. That's a nice little pilot project. It's going to give us a sense of how this works, but we need more funding to develop a community-wide data integration system that can really help providers effectively speak to each other about clients that they're serving and also protect privacy of those clients. The second to last item I want to mention is about data differentiation in the high utilizer population. So stick with me here. We have the capacity to determine who's a high utilizer, right? And then we're starting to work on sharing that information about who's a high utilizer to other individuals. I want to suggest that it might be possible that there's some differentiation within that data group. It's not just everybody's a high utilizer and they're all the same. It might be there's some stratification in that data. So you have sort of a high level of individuals who might be somewhat service resistant. They're maybe not going to engage in services. Then you have a portion who you might lose an engagement, and then a final portion that is early on in their process, might just need that appropriate intervention, a warm handoff, and be able to exit out of that recidivating cycle, right? So what we need to do as jurisdictions is look at analysis, we need to look at literature, and look at what are the predictors that point out the covariation with other variables that might indicate someone's success in engagement with services. So for example, if someone had a lot of familial or community supports, is that a predictor of engagement, right? So if we can identify those pieces, not to say that we wouldn't provide an intervention at every level of that stratification, but that we would provide a different intervention. We would engage with individuals differently based on how many times they had been engaged in that criminal justice system, how long they have been engaged, and what types of community supports they might have. Finally, the last challenge that I'll mention is related to the fact that we provide harm reduction and voluntary programs. That can take a whole lot of patience. So sometimes people come in and out of engagement with services many times, and sometimes they'll never want services, right? So that takes a lot of acceptance and patience from the workforce and from community. So we have to continue to explain that these are harm reduction or voluntary programs. Programs that are involuntary come with their own set of challenges. So for example, someone might have negativity toward an involuntary program, or they might feel like there's a violation of their autonomy, right? And so we want to make sure that we understand there's challenges both ways. And if we go this if we go the voluntary harm reduction route, we need to understand that there are going to be challenges related to engagement with clients, particularly high utilizers. I'd lastly note that what people think they need and what we think they need are not always the same thing. What community thinks people need and what people want are not always the same thing. It's important to know that, to meet people where they're at, and to acknowledge that there's different interests in terms of community interest and client interest, right? And in my opinion, in terms of service provision, we really want to engage people where they're at and connect them to the services that they express that they need. So I think with that, I'll close. I want to thank you again for letting me come to speak. Really excited to hear the other panelists today, and thank you again.
Okay. Good afternoon, everybody. My name is Kristen Schillig, and I work for Fulton County Superior Court. I am the project coordinator for the Fulton County Justice and Mental Health Task Force, and I also manage this Familiar Faces project that we're operating right now. So I'm just really glad to be here. I'm always really in awe of my colleagues on this call today, Polk and Bernalillo. Just really excited to be part of this group. Our project is a fairly new project, so I will briefly discuss kind of why we're engaging in this work. Fulton County, if you don't know, is Atlanta, so it's a very complicated city. And those of us working in the field knew anecdotally that there is a group of people who are engaged in multiple systems, but we didn't have a way to figure out who they were. So we agreed as a community that we need to do better to help stabilize this group of people and really figure out how we can reimagine services to be more responsive. And to do that, we knew we needed to build capacity. So we are a small but mighty crew, but we knew we just needed to have more support. So we did apply for a JMHCP grant, which we were awarded. And so now we have a 2-person team, and we're in partnership on this project with Grady Health Systems, which is really the largest safety net hospital in the Southeast. So what's interesting with this work, and because we're kind of new, is we talk about data all the time, and I think it's important to highlight that really we want to put people first. We get sort of in the weeds with data constantly with this familiar faces stuff, and it's just really important that we're talking about people. We want to engage people where they're at and just get the services that people really need and just center people in the work. It's easy to get kind of caught up in the numbers, but just wanted to mention that. So we are a 3-year project. Last year with COVID was a little wild, as we all know, but we spent our first year doing data analysis and just really acquiring the data, doing our data matching, and identifying our pilot cohort for our Familiar Faces project, which is a group of 100 people. We also started some of our cost benefit analysis, which really should sort of thread through all the 3 years, because we just keep finding new ways that our current approach is just really expensive. So in 2021, let's see here. In 2021, like this year, we've spent time really building up our partnerships, sort of sketching out what our process is going to look like, building criteria. Nick Haganey, who's our statistician on the project, is going to get more into the weeds about the data, but we've identified our 100 people looking at our jail information. But from there, and we really want to develop like a criteria to sustain this project. So really we're spending this year just really looking at the pilot group, and then long-term building out a criteria that we can, call our Familiar Faces, or center our services around that. We've been working on MOUs this year. We have a business case that our Fulton County commissioners have supported financially, where we're building out a data integration warehouse. And then next year we'll be spending time really just, trying to get some money to really build a service delivery around this group of people. Hopefully we'll have our integrated data platform and really some shared responsibility. So yeah, and money, right? We all need money to do this work. Let's see, next slide. So how did we identify our Familiar Faces? So it's interesting with the Bernalillo team and the Polk team, their what we call source data is behavioral health data, but our source data is the jail. So we started with a 3-year data extract from 2017 to 2019 with our Fulton County Jail, and we looked at the people who were booked the most frequently into Fulton County Jail, and looked at all jail episodes and reorganized that so it's just sort of easy to see. And we did, I just also want to mention that we worked with a research partner to kind of help guide this process. And then from there, we looked at our partner agencies to say, okay, we know these are the folks that are interacting with the jail a lot, but we wanted our partners to like cross-reference that information so we know who in the community they're engaged with. And we knew that, Grady Health Systems, it's the huge safety net hospital. We knew obviously a lot of people would be going to Grady, but we wanted to see who else is working with this group of people. And really what we found at a very high level is that a lot of our folks that are in the jail all the time are really disconnected from the community service providers. So as an example, we have a LEAD program here, which is a law enforcement assisted diversion. And of our 100 pilot group of people, only 3 or 4 were actually connected to LEAD. So really that's a big problem, right? So the data really helped us in that cross-referencing, helped us see where those gaps are and how we need to, connect the people with the services. So yeah. Okay, so I think what I'm going to do now is pass this over to Nick Haganey, who's the statistician on this project. And Nick comes from public health, and I guess my word of advice is, if you can get yourself a public health person on these projects, you'd be doing yourself a favor. So anyways, let's go to the next slide, and I'm going to turn it over to Nick.
Thank you, Kristen. So I will give an overview of our data analysis and cross-systems matching. Like Kristen said, our source data was the jail. So we started at Fulton County Jail. It's the county jail. It's the biggest jail in the area. And we identified 100 people who accounted for the most bookings over a 3-year period, 2017 to 2019. So those people had over 1,100 bookings. They accounted for 1.5% of all bookings over the time period, despite being like 0.15% of the individuals booked into the jail. We then turned our attention to Atlanta City Detention Center, which at this point in time is a very small jail. The average daily population hovers around 25 to 30 people per day. It really began shrinking in 2018 with the implementation of bail reform and shrunk further with the cancellation of the contract with ICE. But we found that our pilot group of 100 people had 855 bookings at ACDC in the same time period, also accounting for 1.5% of total bookings. And the days spent in jail, these 100 people spent over 38,000 days in jail, despite their charges being generally low level. And I'll get into some of the charges on the next slide, but like 40% were for either criminal trespass or possession and use of drugs. So after we had identified this pilot cohort, we engaged in this cross systems match. And on the right side of this slide, you can see the major organizations or agencies that have touched these individuals. Data matching with Atlanta Police Department turned up 87 of our 100 people had over 3,600 arrests in an 11-year period, which is an average of over 41 apiece. And I mean, if we're talking about familiar faces, these people are very familiar to Atlanta Police. At Grady, we turned up 28 of our individuals who had been seen 704 times in 4 years between 2017 and 2021. And the majority of those contacts were for substance use in the ER or engagement with the psychiatric unit. And we also have managed to get a couple of our people connected to ACT teams. Furthermore, we found that 88% of our 100 people are enrolled in the homeless management information system, suggesting, that we have a huge housing crisis. We don't have places for these people to go. And the churn of, being in and out of the jail, in and out of the hospital, every time they leave one of those areas, they're right back out on the street. We also found that 18 of our people had been referred to for competency evaluations. And so, just thinking about the relationship between familiar faces and people in crisis, we don't want the assumption to solely be that crisis means a mental health crisis, because we certainly do find that in our data, but we also have found that housing is a crisis in our community, and that most of these people are unable to access general quality of life needs in their own communities. And also the fact that nearly 20% of our pilot cohort has been evaluated for competency suggests that a lot of them are just getting tangled up in the competency system. And it is not leading to the outcomes that we would like. And so next slide. And so I mentioned the charges that our folks are brought in on. And so this represents a little over 50% of all the bookings that our individuals have had. And criminal trespass and possession and use of drugs are right there up at the top, but all of them are pretty low-level, nonviolent offenses. And when we combine like criminal trespass, possession and use of drugs, possession of marijuana, and then that one at the bottom, which is a combination charge, that makes up over 38% of the charges that are given to this group of individuals. And so we used this analysis to inform another analysis that we've been working on, which is what we're calling our crimes of interest. And so crimes of interest are specifically criminal trespass, possession and use of drugs, shoplifting, marijuana, and then a quality of life charge where we folded in things like criminal damage to property, drinking in public, pedestrian offenses, public indecency. low-level crimes that are kind of all over the place, but that tend to represent people who are in some kind of crisis. So next slide. And so some of the key takeaways from all of our data work has, I mean, you can see them right here. So, I mean, our familiar faces are booked in 10 times more frequently than the average person booked into jail, and they use 20 times the number of bed days. Women are overrepresented in this population. They're 3 times more common compared to the average jail population, and that there is significant racial disproportionality. Fulton County is about 51% Black or African American, and our familiar faces cohort is 92% Black or African American. Furthermore, these individuals are, represent a large cost to the jail and the county. In this 3-year period combined at the 2 jail facilities, they accounted for almost $4 million just on housing them in the jail. That doesn't even, take into account the costs associated with arrest, the costs associated with their court dates, the programs or probation that they're assigned to, and it doesn't account for their interaction with other county, city, state systems like Grady Healthcare or our community service providers. Furthermore, when we just are looking at these crimes of interest, people who are booked in only on these low-level misdemeanors, those charges and those bookings represent about 8 to 10% of annual bookings at Fulton County Jail and 30 to 35% at Atlanta City Detention Center, and make up, $16 million for 3 years. So we are advocating for, well, this money could be spent better elsewhere. It could be used to set up supportive services, to fund a diversion center, to just better, to allow these people to have better outcomes and not just continue this high cost churn that does not help them and does not help the county. Next slide. And so, to address this, and Charlie mentioned it as well, we all have data sharing problems. Our systems do not talk to each other very well. And I mean, this leads to a lot of inefficiencies, and it leads to people getting lost in the system. People are let out or released from jail, released from the hospital, and they are released to essentially nothing. So it's no surprise that their crises reoccur, that they continue having the same problems that led them to the jail or the emergency department in the first place. And so we have begun the work to kind of knock down these barriers to unsilo this data and to allow all of our agencies, service providers to speak to each other, to better coordinate their work, and to provide better outcomes. So next slide. So our short-term solution has been the setup of some basic dashboards related to our stepping up key measures, as well as tracking our familiar faces population. So these are just some screenshots of our dashboards, and we have a screening tool when an individual is booked into jail to screen for mental illness. So we're tracking the results of those screenings. We're tracking the length of stay for people who screen positive for mental illness versus negative for mental illness. And we're using this, to inform our work, to provide some discharge planning and just some case management, care management coordination for these folks. But this is not the long-term solution to our real data needs. This is nice, and this represents, a big jump from where we were a year ago. But, this is just criminal justice data. This is essentially just booking data, and then we can get, the case data, probation or program assignment data from that, but we don't get a full picture of people's issues. So next slide. So our long-term solution is to build a data integration warehouse, and this would be a HIPAA and CJIS compliant warehouse that would bring data in from all of our partners. And we've identified, some key agencies that we want to target for data integration immediately, with then the hope that we can bring more and more in as the project moves along. And so, specifically, we want behavioral health, we want housing, and we want medical data. And then we also want to be able to put a lot of this data into the hands of first responders so that they are empowered to make a decision to not take someone to jail, to divert them from arrest, or to, contact one of the agencies that this individual is connected to, so that we aren't just continuously locking up the same people. And so, the long-term goals of this are to just bring in all these data sources to match individuals between systems, and to get a holistic view of these people's involvement in the city and county. Next slide. Oh. I'll turn it back over to Kristen.
All right. Well, thanks, Nick. So here is the Fulton County representation of the continuum of care for people in crisis. I think the checklist is helpful in really assessing what our current resources are kind of broadly, but I know here in Fulton County, we are really digging deep into really our capacity issues. So we have some, bare bones infrastructure in some of these checkmark areas, but we really need to scale up in order to be more responsive to people in crisis. So next slide. So briefly, this is our current landscape, and as Charlie mentioned, we are really working towards framing out our continuum of care into someone to call, someone to respond, and somewhere to go. So in the somewhere to call, we have Georgia. We're really lucky. We have 2 peer warm lines to the Georgia Council of Substance Abuse and the Georgia Mental Health Consumer Network. We have our Georgia Crisis and Access line, which is attached to a bed board, which can dispatch co-responders, mental health co-responders. We have a new 311 project, which the city of Atlanta operates. It's a non-emergency call center set up to take calls about concerns like potholes and missing trash or recycling. But in February of this year, 311 began taking calls from people who want to report community concerns related to mental health, substance use, or extreme poverty. And as an example, like if somebody sees someone sleeping outside, people in the city of Atlanta can now call 311 instead of 911, and a harm reduction team is sent out to assist that person. So we're really proud of that project. Obviously, we have 911, and then 988 is on the horizon, right, for all of us. In our someone to respond, we have our housing outreach teams, co-responder models, police, obviously. Our policing alternatives and diversion program, which is our lead project, but they are actually the people now responding to those 311 calls. So it's all kind of tying together for us in this sort of pre-911 like space. So we're really excited and super proud of these projects. And then for somewhere to go, we are really lacking. I get always super jealous of Polk and Bernalillo County for all their resources. We have generally like a psychiatric ED, some housing programs that are not adequate for the need, and of course we have our jails. But right now we're spending a lot of time trying to kind of build up that infrastructure for somewhere to go, building out what a sobering center should look like for us, our peer respite centers, and we do not have a behavioral health crisis center, so working on that. And then some law enforcement diversion drop-off sites. So a lot of work to do and not somewhere to go space, but we are making progress. So I really, just to wrap it up, I think that for our next steps, we are working with our Atlanta Police Department to redirect our familiar faces to our PAD project. As I mentioned, there's that disconnect between our familiar faces and the service providers. So right now we're really working towards getting that done and building out our triage process and just trying to get some money, guys. So I think that wraps up our Fulton County and Atlanta presentation. So I think we're going to pass it along to Annie.
All right, thank you. Next slide. So I'm Annie Utes with Polk County Health Services, and I work for the department in the county that oversees all of the mental health and disability services. And so my main job is to oversee the contracts for our crisis services and all of our care coordination. Polk County, just so you guys have an idea of who we are, how big we are, we have a population of 490,000, where the state capital of Des Moines is located. We have 15 different law enforcement agencies that we work with. Our current jail capacity, right now is 1,200, but it can go up to 1,500 if we need. But our daily census of yesterday was 724 people from Polk County, and then 201 federal cases. So those are U.S. Marshals and cases that we're holding for them. And then 50% of the people who are booked into our jail are released within 24 hours. So it's quite a bit of turnover and people are not there very long. Next slide, please. The cool thing about the three of us that are working on this project together is that each of our programs operate very differently. And we're looking at things in a different manner. And so you'll see that mine is a little bit different than everybody else's, which is a good thing because it might help you kind of decide which way to go for yours. In the fall of 2017, we were part of the Data-Driven Justice Initiative, and we were invited to attend the Data-Driven Justice and Behavioral Health Design Institute that was located in Maryland that fall. So we took a group of about 9 people, I think, to that institute, and we learned about what a frequent utilizer was and kind of what you could do. It was really just getting off the ground. And our group came back and said, this is what we want to do. We really want to help this group of individuals. So they identified that we wanted to develop a familiar faces platform that we could use to identify those individuals. We reviewed several platforms that were already available that we could purchase. And our IT team decided that they really wanted to build it on their own so that we could really tailor it to our county. And so they started working on it by using just public information so that we weren't having to worry about HIPAA, which was kind of their big thing, is they didn't want to have to deal with all of those rules and regulations. So they pulled in our jail bookings and our 911 calls into this platform. So I can see the top 100 jail bookings, I can see the top 100 911 calls, and then they can blend those together. The problem is that the 911 calls were very difficult to utilize because a lot of them didn't have names, we just had addresses. So we were trying to put the addresses from the 911 calls together with the addresses of the jail booking, the people who had been booked into jail. And it was really difficult to use those 911 calls. So that part of the system, I just don't utilize that frequently just because we can't get it figured out. The platform has a messaging system within it where we can message back and forth between those who have releases about individuals. So it's enclosed and encrypted, and we don't have to worry about it going through just the regular email system. It has a place where we can upload releases, and we have a data sharing agreement and a universal release that we can use. When the pandemic hit, everything just kind of stopped, and the pandemic became our priority. The jail was really concerned about how they were going to operate. Our police force was trying to figure out how they were going to operate. Mental health, we all went home to work from home, and we're trying to figure out how can we do telehealth. So we kind of got off track. So we're just now finally starting to get back on track. So just, I figure everybody needs to give themselves some grace period right now due to everything that we've been through over this last year and a half. So what we did and how we've kind of recovered from all of that is over the years since 2017, relationships have really been built between Polk County Jail, our Des Moines Police Department, which is our largest city within of those 15 different law enforcement agencies, our Des Moines Fire Department, and then the Ankeny Police Department, which is one of the 15 law enforcement agencies. They were kind of our guinea pigs on really working with our familiar faces. Along with that, then, we have these other core partners that are listed here. The region is where I work. Polk County IT is a large part of this. And then Community Support Advocates is a local community-based service agency that provides care coordination and some services. Broadlands Medical Center is our county hospital, and Irely Ball Community Mental Health Services is one of our community mental health centers. So, and they provide our jail diversion within our jail, and then Broadlands provides all of our crisis services. So we are kind of the group that is working together really to work towards developing services for these individuals. How it's kind of panned out since the pandemic and over the year is that instead, they now are emailing and calling me. So Des Moines Police Department or Des Moines Fire or Ankeny Police Department, if they have an individual that they have identified as a familiar face, they will shoot me an email or a phone call while they're on the scene and say, hey, I have this person that needs support. I then can look them up in our Polk management system for mental health. We have a mental health system, management system where about 30 different providers are connected to that system. So I know at the time who's working with which individuals. So I can look up, see if the person is connected to our system. And if they are, then I will shoot an email out to those individuals who are working with them. And then they can contact the police or fire department once they have a release of information if they don't already have one. If the person is not connected to our system, the fire or police officers will talk to the individual, see if they would like to get connected, and then a referral is made. And then once the releases are gathered, then we can all talk as a group to resolve the situations. We also put into place quarterly meetings with law enforcement, mental health crisis service providers, our ER, heads of the ER, and our pretrial release program. So we all get together on a quarterly basis to discuss how things are going. We bring in resources. Actually, this next week we have a meeting and we're bringing in search and rescue dogs because we didn't even think about it, but they can search and rescue for individuals who walk away from their homes and we can't find them. And so we're going to talk with the police about utilizing them for that because we do have some familiar faces where that's the case. So those meetings have been very beneficial to build relationships between all of those service providers, law enforcement, and our ERs. We also, in that group, we had some issues with a couple of our ERs in town where the drop-off from police was not going very well. So we worked through policies and created policies so that all of our ERs, the police can bring the individual through the ambulance bay and drop them off in a more secure and private environment rather than having to walk them through the emergency room lobby and sit there with them. Along with that, we have a post-booking jail diversion program that's ran through our community mental health center, but they're located at the jail. And every morning, they look at all of the bookings from the night before. They review them to see, I call it magic. They match their system with our mental health system to see who is already connected to services. And if they are connected, then they talk with the care coordinators in the community so that when they go in front of the judge for that initial appearance, they can talk about what services can be provided so that maybe we can get people out of jail sooner. And then if they're not connected, they get them connected up with our system if the person's willing. Along with that, we have the jail management system and our PLC MIS system, which is our mental health system. They also have magic that happens together, where every morning an email gets sent to the care coordinator through the mental health system that says that their individual was booked into jail. And then when they're released, they also get an email stating that they've been released. So it's just better continuity of care by being able to know where individuals are at. The other thing that we offer up at our jail is if for anyone who has been in the correctional system in the last 2 years, they are eligible for up to 6 months of free psychiatric medications through a pharmacy program that we have. So that is always available for those who don't have access to insurance or Medicaid and need to have psychiatric medications. Next slide, please. One of the things that I wanted to look at was the relationship between our familiar faces and our people in crisis. So for our familiar faces, is for anyone who overutilizes our emergency services. So I know that the others are looking at their jail and court systems. We're really looking at our emergency responders, first responders. So jail can call me, but also fire and police. So if they have people who they're seeing frequently, who they identify with a mental health, substance use issue, developmental disability, or any medical issues, we're willing to go out and assist with them. 21% of the people who have been identified as familiar faces are connected to our long-term services and support system. So that means a lot of them are not connected. And so we need to get them, at least offer them those services as they are voluntary. We also looked at the individuals who were identified as familiar faces and if they accessed our crisis observation center, which is a 23-hour observation center. And in FY18, only 3% did, in FY19, 6%, and FY20, 5%. We would really prefer that they would utilize our crisis continuum of care rather than calling first responders. So this just shows that we need to get more word out about our service array, our continuum of care, and do more public service announcements to hopefully get people connected to the right services so they're not calling 911. Next slide, please. This just shows everybody before me talked about their different list of services, so I'm going to move on to the next slide from here. I wanted to show what our continuum of care for people in crisis looks like. So if somebody gets in touch with police, fire, or our jail, the hope is that they will be diverted rather than taken to jail. And so the majority of our police force is trained in CIT throughout our whole county. The orange are the services that are already available to our police, fire, jail, and even to just the community at large. So we have a mobile crisis team, and I'm not going to go through all these because Charlie did a really good job of explaining what a lot of these services are. But they're there. We just want to make sure I go out and do trainings with police on a regular basis so that they understand what our community has to offer, and hopefully they're diverting people rather than taking them to jail when it's a minor offense that they could do a citation for, or even not charge them and just take them to connect them to treatment services. Next slide. The one thing I did want to talk about is our continuum of long-term services and supports. If you have a really good base of long-term services and supports for people to access and to be part of, hopefully they won't need the crisis services. So that's where we've really kind of tried to develop a really good continuum of care in the community. So anybody in the gray boxes can make referrals to our coordination agencies. We have 3 that work with mental health coordination agencies, and then we have 6 total when you look across all disabilities. So And like I said, any door you can walk into, because all of our systems are connected through our computer system. So we know, if they walk in one door, oh, you're already working with this provider, so let's get you reconnected with them if you, forgot you were working with them, or you haven't met with them for a while. But you really need to have, supported community living services where somebody can come in and help them in the home or make sure they're taking their medications. We have a forensic assertive community treatment team, along with just a straight assertive community treatment team. We have integrated service agencies, which are very similar to an ACT team, only they don't have a psychiatrist on staff. So the person would see their community psychiatrist. And it's a lot more flexible than some of our Medicaid funded services where you have to make sure you're maintaining those Medicaid regulations. But if we can get people connected to employment, get them housed, get them services in their home, and start working towards education and employment, as you start increasing all of those services and getting them connected to really create a role for them in society, then we really have seen our outcomes for our homeless days, our jail days, our ER visits, our hospital days, those really drop when people are connected to employment and housing, safe and affordable housing. We keep about, I think it's like 16 different outcomes on all of the individuals in our long-term services and support, so we can track to see, as they get connected into employment and into community integration and getting involved in their community, you can see those outcomes for homeless days and jail days decline and go down. So this really is the key to making sure you don't have to utilize those crisis services, is really developing a good long-term services and supports continuum. I think that was my last slide, but I'm not positive. So I'll turn it back over to Mark, I believe.
Yeah, thanks, Annie. And thanks everyone else. And I tried to do the transition between Charlie and Kristen, but my audio was muted and then I got disconnected. So apologies for that. But thanks so much everyone for the great presentations today. And we had a lot of questions pour in too. And I'd encourage folks listening in to still enter their questions into the Q&A panel in WebEx. But we went through the questions, and a few of them clustered around if it's possible to share certain things like the ROI, MOUs, and jail discharge planning policy from Bernalillo, and the screening tools and case management tools from Fulton County. So if that's possible, we have the presenters' emails at the end of the presentation, and I think they'd be happy to follow up through email to share those.
Sure, we'd be happy to share, Mark.
Perfect, thank you.
Yeah, we are too.
I
tried to address one or two questions from the chat, but I am happy to receive any emails.
Okay, great. Thank you, Nick. And then one specific question we have is, and Charlie, I think this one is for you. Does 911 dispatch have the ability to transfer the 911 calls to the mobile crisis team? And when they determine that it's a mental health crisis needed, not a medical emergency?
Yes, absolutely. So that's how that process works. So someone calls into the 911 dispatch system, that dispatcher asks them where they are and what their emergency is. And if they're expressing a behavioral health need, then they go through that to the behavioral health tab of their EMD booklet to determine how that particular call is triaged. In some cases, a behavioral health call needs to be triaged to a higher level. So if someone was barricaded in a unit and saying they were going to shoot individuals in a building, then that would be a SWAT response rather than an MCT response, but dispatch is responsible for determining the appropriate response protocol. But if it was appropriate for the mobile crisis teams, then they would find a mobile crisis team, make sure they're available, and then dispatch them out to the scene.
Great, thanks, Charlie. And then there was a question about the peer warm lines, and I think this one is for Kristen and Nick. Could you explain a little bit more about the peer warm lines?
Sure. So The peer warm lines are run by 2 different agencies. One is the Georgia Mental Health Consumer Network, and one is the Georgia Council on Substance Abuse. And they're purely a peer-led agency, and they operate these, I believe they're 24/7 call centers where a person can call and just get supportive help, or just have an opportunity to talk to somebody. I can put the links to the agencies in the chat box if that's helpful, but they're really great. We include them, in all of our work. So yeah, but I can put their links in the chat box if that's helpful.
Yeah, that'd be great. Thanks, Kristen.
Sure.
And then a question, I think this one is for Annie, but discussing the prescription program upon release for folks releasing from jail. And the question is, in their jurisdiction, it's hard, or they're wondering if it was hard to set that up.
So we actually won a lawsuit against, I don't know if it was Johnson & Johnson or Janssen or some company. And so the state of Iowa took that money and used that as kind of our startup for it. And so they put that money into an account. They hired a pharmacy to do this for us. And then that pharmacy uses the sample programs through the different agencies. They also do, get people connected through that. Or if they don't have the medications they need, then they purchase them with this money that we used from this got from this lawsuit. So what they do is when a person leaves the jail, they go to our we have a psychiatric urgent care center. So they can go to the psychiatric urgent care at our county hospital. They are seen by a prescriber there, and then the prescriber gives them, because the hospital has a pharmacy themselves, gives them like a 5-day supply. And then SafeNet RX, which is our pharmacy for this program, mails them the rest of the medications for the next 30 days or 90 days, depending on how much they can handle at one time. If the individual is homeless, then they can mail those to our county hospital, and then they can pick them up at the county hospital.
All right, great. Thanks, Annie. Mm-hmm. Another question is, did you have to buy a new database or upgrade an existing database in order to flag the high utilizers? And Charlie, I'll start with you, and then Annie, and then Kristen and Nick, if you want to hop in, feel free.
Yeah, absolutely. Could you ask that first part again?
Yeah, did you have to, for the database, the system for tracking the high utilizers, did you upgrade an existing system or buy a new system?
Thanks. Yeah, I want to make sure I got the question correctly. So we are working with New Mexico Tech, which is a local community college, and they have worked with a database developer to develop that integration system. And similar to what Annie described in terms of wanting to build it out for our specific purposes, it was too difficult to build something that already exists kind of off the shelf and then create it to fit the needs. So because the needs were so specific, they asked this designer to do that. It's a pretty complicated build out. Actually, it includes the development of being able to have all of those MOU participants in the database. And then depending on the ROI status of the particular client, it will loop that provider in to be able to access particular pieces of data. So it's a little bit complicated in that way that everybody gets access, but not everybody has the same level of access to certain types of information. So that's really important to think about, and we've had to talk about all of the details of those things. Our department is in the process of developing a database as well, and so we've had to connect their designer with our database developer to talk about the transfer of the ROIs over into that system and the data into that system, so we didn't have someone actually manually entering the data. So I think that, like I said in my presentation, it's a pilot project, and it's really great. It's awesome that they set it up, and it's not enough money to really develop it out and maintain it in a way that we need to. And so we've got it up, and now we're going to have to find some more funding to continue to maintain that system and include more information as we develop out our process for sharing ROIs, having clients being able to share their data, and including new providers and things like that. So hopefully that answers your question. I think if, like I mentioned in my presentation, I think if we were to build out a larger system that was really large, that would include the jail and the emergency room and community providers and other criminal justice partners, we might want to go with a larger database design that's sort of developed out to do something like that. But as I mentioned, we're in the process of starting small and seeing how that goes.
Yeah, and so ours also was developed in-house. Polk County IT did that for us. And so we really wanted it to meet the needs of our community and not just buy something off the shelf. We've done that in the past with several other projects and it just didn't work. So everything that we have, we've developed internally.
For us in Fulton, our county currently has a contract with Tyler Technologies, who operates Odyssey, which is our criminal justice data information system. And so we're leveraging that existing contract to have them build out this data warehouse, which will essentially just pull the data from those organizations that have signed on to our MOU. And of course, the universal ROI will be taken into account. We won't be sharing information on individuals who have not consented to share their information. So we are not purchasing a new data system. We are simply expanding the data system that we are already operating. So all of the current dashboards that we've built will just be like added on to what we are building through our data integration project.
Great, thank you all. Another question we have is, how is success quantified, and do you have any stats to share? And I know that the answer looks different because you're coming at this from different perspectives and you're at different points in your project, but can you speak a little bit to what success looks like?
I'll go first if that's okay. So I don't have specific stats, I have stories. We have an individual who was calling our fire department 5 to 7 times a day. And I think it was 2 days ago, when I talked to the fire department, they had not had a call in 3 weeks, knock on wood. So that is a huge success for us because it was pulling a whole firehouse off of the streets every time he called, which was 5 to 7 times a day. So that's one of them. We had another person who was walking away from his group home in the middle of winter, and we were always afraid that he was going to freeze to death before we could find him. And so when the police finally called me, I worked with that group home in order to set up some supports and safety plans so that he could no longer walk away without them knowing he was walking out the door. And so there's been no more calls for service since that occurred. So ours is really, do we have calls for service or have they gone away? And so we look at that. So the fire department and the police departments know who those people are so that when they start seeing an uptick, they contact me again and we get supports back in there to see, did something change? Did we reduce supports for a while? And so because they were doing well and now they're not doing well. So just that constant communication with each other is very beneficial so that we can make sure that those calls for service remain low rather than utilizing our first responders.
Thanks, Annie. And then Charlie or Kristen and Nick, do you want to weigh in on this?
I can jump in. It's a difficult question, so I'm still thinking about it. I think in terms of how do you measure success when we're looking at the identification of a high utilizer, I think part of it is if we were to go to different organizations or spaces where these high utilizers are engaging with services. So the jail, the hospital, substance use services, if we were to go to those locations and talk to them about who they're seeing most, who their high utilizer list is, if those lists are co-varying, if we're seeing lists across different providers, the same clients, then we know that our indicators that we're using to identify utilizers are working, right? And I think it was Kristen who mentioned this idea that, oh, we crosswalked it with our lead program and there wasn't a lot. And we had that too. I crosswalked some of our data with our crisis unit here, which is a crisis stabilization unit. And there wasn't as many as I would have expected. And I think that challenges us, and it asks us to think larger about other indicators we might want to include on our frequent utilizer list to be able to better hone in on that population. So I think we have a list, and now we need to know, is that list really capturing that group? So I think that's an interesting, so the identification of the list and success of that identification is one piece, and then that connection of services, and just like Kristen mentioned, being able to hone in on, there's like sort of, 10% of clients that are taking up 70% of services or something. I'm sure you guys have heard that statistic. I don't have it offhand, but something like that. And when that happens, to be able to look at some of those individuals and how they're engaging over time. And if you were able to see some of that engagement decrease, then you would hope that this connection to a crisis system is effective.
And I think the good thing about how we do it too is because we keep our outcomes for people who are engaged in long-term services and supports, we can then follow the individuals who were on our familiar faces list and are now connected to services. And so we can see the good things that are happening in their lives. We had one gentleman who was, I think he had been arrested 28 times for trespassing when I finally got told about him. And when we were able to assess him, it was due to dementia. He kept walking back to the same home that he had been living in for many years, but wasn't at that moment. And they were calling and being booked for trespassing. So, he now is in a nursing home and has a guardian, and his quality of life is so much better. When we found him, he had feces in his beard. And I mean, it was just a really sad situation, but his quality of life is so much better now, being able to get the services that he needed in order to have a better life.
I guess I know we're at time, so I'm just going to say ditto to what everybody said. What we talk about a lot is just like inverting the burden. So I think, we talk about success. We're spending so much money on our jail right now. And what, success is for us is just an investment in the things that we know or hope to know that will, invert that burden, because we want to invest in our communities and our people and not the, cycle of incarceration. So that's all I'll say. Thank you, everybody.
Yeah, thank you. And as Kristen said, I know we're just a little past time, but I want to make a quick plug for the office hours and upcoming webinars in this series. So we had a few questions that we couldn't get to during the presentation today, but on June 24th at 1 p.m. Eastern Time, we'll be holding a follow-up office hours session. And so that'll be less presentation focused and more of a panel discussion where folks who are on the line can ask questions of our panelists. And so hopefully that'll be a good way to keep the conversation going. And then we'll have the second and third webinar in the series, hopefully in September and then December of this year. And then I think just on the last slide, we have contact info for the panelists, their emails, and we'll post the recording along with the slide deck, hopefully by the end of next week. And so that'll be available on the Justice Center's website. But want to give a very big thank you to all of our panelists. It was really great information, and we're looking forward to the office hours next month. All right, thanks everyone. Have a great day.
Thank you.